Now, this subject of facing surgery is truly, it's what I've learned and what I must tell you. So this is why this presentation, I feel, is with false risk. This is the other presentation that I think is very important. Joint surgery and joint replacement surgery is not uncommon for late effects. If you keep wearing away your joints, at some point you'll go under the surgeon's knife. If you fall, if you don't pay attention to false risk, you're going to end up under the knife. So it is becoming more common. That's the problem. Now, it's not just polio alone, right across all late effects. It's becoming an issue. So the information in this presentation that I'm going to give you comes from the experience of the clinic I run, Late Effects of Disability Clinic. And initially, it was a damage control situation. For example, because I am in a big rehabilitation hospital, and we do specialized surgery, the physiotherapist in the surgical unit would call me and say, Jega, we have a patient who says he has seen you. Can you come and help us because he's already been in hospital for 2 weeks and we still can't stand him up. Right? And when we go there, they haven't done the basics required to keep this person moving while he was lying in bed. And the surgery is to the stronger leg. And so this is a common picture. If patient has come in, wheelchair, surgery to the arm. You need your arm for transfers. What do we do? So these were the questions. And sometimes it was high cost. One young man had to stay in hospital for 3 months. And even when we sent him home, he had to have a carer full-time initially. So can you imagine the cost? Close to $700 a day bed. That's close to 3 months. All because we didn't plan for it. So now we have learned from the past, and we now use a more proactive approach, which is why I keep my mantra to you has been, get an assessment done, hold on to the assessment. Make sure you have it in your hand so that when you go and see a physiotherapist, like all my patients do, they can either tell the physio, please talk to Jega because she has a full assessment on me. And the physios do make an effort to phone, they will, because it makes their job easier. It makes the job of a physiotherapist easier if they know what you could do before and how you did it. Okay? So now it is a proactive approach. They call me, we go, we discuss the patient's problems. I can just tell her orally. So all physiotherapists speak the same language. So they can explain to each other, so-and-so, Annie walks this way and she transfers this way. So if she's going to have a surgery for her arm, this has to be in place. Okay, so that discussion happens before, and that's the text of my talk. What is the discussion that must happen before the surgery? Because it's too late after the surgery. So that's the proactive approach we have learned. But more important is to empower you, the client, to ask the right questions. So that's also the text of my talk today, is to give you the power by telling you what are the questions you really need to ask. And you must have the information written down. Again, this presentation is going to be left behind with the Polio New Zealand, so take it from them. Now, for those who have internet, please look at this, Preventing Complications in Polio Survivors Undergoing Surgery by Dr. Richard L. Bruno. The article I think Anne has on her computer. I actually asked her to print it out because it's a useful one for you to take away. We didn't print it out anyway. Pity. It's a brief, what the article does, it's a brief overview to inform patients and professionals about the cause and prevention of complications in polio survivors undergoing surgery. So he covers everything from anesthetic to the point in time when you go home. It's a nice article. It's a brief overview. So it's an easy one to read. Okay. Why you need to state the obvious? It's not obvious to others how clients with polio have adapted to self-tasks like getting out of bed, getting on and off the toilet, personal hygiene management, showering and dressing, activities of daily living like cooking, house cleaning, shopping and socializing. You go for surgery, you're sitting in a chair, the doctor talks to you sitting down. He doesn't see what you're doing when you enter the toilet. And for those of you, for example, the ladies, you're using the frame. The way you walk, if they have a surgery to your arm, you're not going to be able to use that at all. But the doctor is not going to know that. If he does surgery to your leg and he puts on even a small plaster, say surgery to your foot, and he says, don't put weight on that. What are you going to do? But that's not obvious to us. Okay? Remember, we are seeing you sitting down, we are talking. It's not obvious how you then go home. And one of the common things all of you do is you lean against a counter when you're cooking and you're washing up. You do it automatically. You don't even think about it. But if the doctor says you have to go home with a frame, now you can't lean against the counter because you're that far away. See, you don't realize it, neither did anybody else. And you're only going to find that out when you do go home. So that's the point I'm making. It's not obvious to us. So please state the obvious, even if it sounds a bit silly. Wasting and weakness of muscles of your trunk, of your body, your shoulders and your hips. It's not obvious under the clothes you're wearing. And the only time anyone asks you to take off your clothes is really on the surgical table. It's too late then to see this person is so wasted in the hips. It's very late. So that's the other reason why you must state the obvious. Movement skills have been learned over decades. You've got 60, 70 years of learning. This learning is now automatic, and the brain fine-tunes all these skills to produce a unique style of movement. Every one of you moves differently. Every one of you. You may have a similar weakness, but each of you have adapted over decades and decades and decades. Now, when a small portion of this unique movement is taken away, the brain needs time to adapt to that. Okay? And it'll get over it, but the brain needs time. Okay? And you need to know, this has changed, therefore I have to think about moving in a different way. So even a small change is quite a quantum leap for movement for you, because you're fine-tuned your movement so much. It's not obvious to you. This is again why, my soapbox is please get an assessment, so that the assessment, talking to the physio, you will discover how you move. If nothing else, you will discover how you move. If nothing else, you will discover which muscles are strong enough to take your body weight, which muscles are not. Okay, so that our testing will tell you that. So, questions you need to ask before the operation, before. The answers given will give you information on how to prepare yourself for surgery. And some of the right questions to ask are, these are generic questions. Ask the doctor about the length of bed stay required. Inform the doctor or surgeon that inactivity in a polio muscle will only weaken the muscle. If bed rest is required, you must be given a list of bed exercises to keep your muscles ticking over. Therefore, who will do this? Will you have access to the physiotherapist before the operation and after? Because usually it's only the physiotherapist who gives you the exercises. So that is why I started with a very boring subject about cells. Okay? Understanding the cells in your body. Because I've already told you, you've got aging and you've got a red card. You've got a number of red cards given to you because of the polio. So that together, if anything, remember that 1.5% per day weakness. Just remember those pros. And if you need it, get the information and show it to the doctor. And I have the references to the information given. So if the doctor thinks you're making it up, tell him to look up the article. Okay? So it is all written. It's there. The science is out there. But for polio, the more you stay still, the faster you weaken. So understand that and tell them. All it needs is the right exercise. And so that's the first question. How long will you be in bed? Who is going to come and show you exercises? And when will the physio come? Can you meet the physio before? Next question. Ask the doctor, surgeon, or the pre-op. There's something called a pre-op team, usually. So you usually meet just before the operation, a few days before or a week before. And even at the most, it may be only a nurse and a doctor, but at least ask the nurse, is there a physio I can talk to? So will you require a walking aid? And for how long? So he's doing surgery to you. You must ask, what will I need after the surgery? Can I take weight on the leg? So will I need a walking aid? And how long will I need the walking aid for? Now, if you have had difficulty using walking aids, bring this up now. Many of you cannot use a frame because you walk sideways. The ones in caliper, you walk sideways, which is why you can only use sticks on the side. Anything to the front throws you off. Many of you who are walking with a frame leaning forward, you won't be able to use a stick because your knees are so hyperextended, so backwards. Your knees have gone so far back, you have to lean forward. Okay, you've got to lean forward. So if you have not been able to use these aids before, tell the doctor, if I'm going to use a frame, doctor, I can only use a stick. I could never use a frame. Now, if the doctor says why, now you have that lovely physiotherapy assessment. You show the doctor that. What can you do? And so these are the discussions you must have. How do I walk? Why is it that I walk in this way? So that understanding alone will let you know why you couldn't use a stick or a frame. Some of you can, some of you can't. It's really mechanical. The body is a machine. It's like a tower. It's as simple as that. When and how much weight can you put on the operated joint or operated leg? So if you've got to put, the doctor will say partial weight bearing. They just write partial weight bearing. You won't know this statement. So partial weight bearing means, 20% weight. Can you take, therefore, extra weight on the weaker leg? And normally the operation is always on the good leg that's been holding you up all this time. You know why? Because wear and tear. The weaker leg has ridden on the back of the stronger leg. Okay? That strong leg that's stood you well for the last 30 years is usually the one they're operating on. Now you are up the creek without a paddle, isn't it? Because how are you going to put 50% weight on the good leg? Therefore, the other 50% must go on the bad leg that has never taken 50% weight. The doctor will not know that. You must know it. So you can ask how much weight bearing and then for how many months. If it's going to go on for 2-3 months, you've got to get into a wheelchair. You may get away with it for 5 days maybe. You can sort of scoot around a bit with, maybe these sort of trolleys. But if it's going to be for 2 and 3 months, you need to hire a wheelchair. So this is why you've got to ask the question. So how much weight and for how long? Okay. When and how, what range of movement are you allowed? All of you are sitting in chairs. The chairs with the back, that's at least 90 degrees. Many hip operation and many knee operations, including ankle operations, will not let you bend to 90. If you're sitting on those lounge chairs, they are more than 90. They're going on now into what we call 120, 130 degrees. That's 90, above that is 130. Most toilets are very low, so they require a hip to bend. Getting in and out of a car, that's more than 130, yeah? So if the doctor says you can less than 90, what are you going to do now? You can't sit in any chair at home. You can't get in and out of a car. Although the OT will address it, but she's got to do more. She's got to look at your home. Because remember, it's a stronger leg that's been operated on. So how are you going to get out of a chair? So even if they give you a high chair, how are you going to get out of it? Because you're dependent on the stronger leg to hike you up. So these are questions you must ask before. You've got to tell us, the allied health team, this is my problem. But you've got to understand your problem first. How and where and who you can talk to regarding access to equipment. So if you need special equipment in your home, if you need extra wheelchair, you need extra height, who is there? Yes, there is something called the health board or someone who supplies you free, but you've got to be able to talk to that person. So who's the magic person that gives you that connection? And if you have to hire, please look at the cost. Can you afford it? That's why you need to know how long. The how long tells you how much money you have to spend before the operation. So now, just for before the operation, you've got to talk to at least someone who's a social worker or a community worker who looks at cost. You've got to talk to the physio, you've got to talk to the OT. So you're already touching 3 people before you even go for an operation. But that's the questions you must ask. Inform the doctor, the surgeon, and the preoperative team. Who looks after whom in your household? If you are the primary carer, so you look after your husband, or you're the husband and you're looking after your wife. That sets a whole new paradigm of cost now, okay? Discuss if your spouse is strong enough to help you. So if you're the primary carer and your husband or wife is helping you, now is the person you're looking after strong enough to help you just move even in bed? Is she even strong enough to lift your leg up? If you have to put your leg on the bed, is she strong enough? Because your arm may be affected by the polio, and now you can't lift your leg onto the bed because you've got a splint on your arm. It is as serious as that, believe me. There's a lot of, it's usually the older population that ends up with wear and tear interventions. So be careful about these sort of operations, what's required. Is your spouse strong enough to lift the weight of your leg, even to move? You may be able to go to the toilet.
Excuse me, you're also more or less telling us that if our spouse who is strong goes to hospital, he needs to ask all these questions.
That's true.
He or she.
So you may need help getting in and out of bed, even if it's to stabilize, I just need somebody to hold. Now, is your spouse strong enough for you to hold on to? Or are you holding him before? That's right. That's the other thing. Those of you who are alone, think about this. Who is there? Who's the person you can talk to regarding this physical assistance and home help? Who is going to mop the floor? Who's going to feed the cat? Who is going to close the front door? It is serious. If you're living at home alone, please, it is serious. Even closing the front door, you've got to hop to the front door. Can you do that? So these are questions you've got to ask and think about before you go. Now, you can't think of all of it, but at least make sure there is a social worker or physio, someone who will go through all the obvious questions. Okay? Personal care and walking. So is there help? Who can you ask? Who can you hire? If you're alone, who can you hire? Who is there to come in and shower you, dress you, help you with all the housework you need to do when you go home? It's too late to ask it after the operation when you're lying in bed and you're very vulnerable and you're all in tears because everything hurts. And you'll never ask this question. Who you can talk to regarding access to physical assistance of home help? As I said, that has to be done before. You might want to ask about private or government-funded agencies who provide personal care and home care assistance. There are. In every country in the world there is. Okay? So, but you need to know because you're never bothered with this. You never needed them before. So where do I go for help? Will the Polio Association have the information? Is somebody in the council? Is there someone there who has the information? You shouldn't have to go to the human rights people just for this. Okay? So you need to know the pathway. It's really a pathway. And one of the big things that Polio Association National can do is start writing these pathways down. And you stick it somewhere. So if I need help like this, I need to go to this person in the community. You might want to need assistance with meal preparation. So even if it's a minor surgery, abdominal surgeries are very painful. Okay? So you've got to go shopping, you've got to go cooking. What do you do? So is there help for that? And then more important, the doctor sends you off with a plaster on your leg and says, come back in 6 weeks and see me. Right. That's right. I've had patients who, and see, even for me I have 35, 40 years working with disabilities. And one day, one of my polio patients said, Jega, I went home and I was a prisoner in my home for 5 days. I had to phone my friend to go and get food for me because she didn't have anything in the freezer. So even to that extent, prepare food, freeze it, so that when you go home, at least for the first 2-3 days, you're not going to feel like going out of the house. You're too tired. It's just too much. And many of you who've had problems recovering from the anesthetic, it washes you out. You've already told me that story over and over again. So have all of this in your fridge ready to go. It may be a good time to lose weight, but that's not the way to do it. Starving is not a way to lose weight. Right. Other questions you must ask the team. You might want to ask for an OT assessment of your home to look at assistive devices to help you with the post-op period, post-operative, after the operation when you go home, till you're fully functional. Assistive devices, not just toilet chairs, including picking things up from the floor. So as obvious as that. Something falls on the floor and you've got a plaster on your leg. What are you going to do? Just really stuck. Yeah. So there are lots of, the technology has moved so far these days. Yeah, a lot. So there's lots in there, but you need to ask the right person. No point asking the doctor. You could ask the OT. He's the one to tell you. Delay in obtaining assistive devices can actually leave you lying in bed in hospital. At my end of the world, it's close to rehab. Our rehab hospital is across the board. It's roughly, I think, $700 to $800 a day. I don't worry about these things. Which is why I work in a public system. But that's per day. That's what's costing the health system. So it's cheaper for them to buy something and give it to you, if it means you can go home sooner. Okay? You might want to ask about post-operative physiotherapy, because you must regain strength because you've not been moving. The leg in plaster hasn't been moving for a while. That's why they put it in plaster, so you don't move it. Right. Now, what happens when they take the plaster off? All that muscles, type 1, type 2 muscles have gone. Nothing is working now. So post-operative physiotherapy is important. If physiotherapy is offered post-discharge, the doctor says, yes, you must come back for physio. How are you going to get that? Okay. How are you going to manage transport? And will transport allow walking aids in the vehicle? So if you are wheelchair bound, or if you have big frames, or if the doctor gives you a very, depending on the frame that you have to use at home, can you take that? How are you going to manage? Will the physiotherapy department have someone waiting to take you in a wheelchair? We offer this, but the patient must ask that. So they come in a taxi, and the front desk, which is somewhere but 300 meters away, needs to know you need a wheelchair to take you to your physio appointment. Otherwise, the physiotherapist is waiting there, 20 minutes appointment, and you haven't turned up because you're sitting somewhere else. But you've come on time, but you're sitting somewhere else because you can't walk the distance. It's the logistics that we as physiotherapists just give you the appointment. In fact, often it's not even, I haven't seen you, it just comes in a form. And my secretary has phoned you and made the appointment. But you are responsible for this. You must tell, I need help to get, so I'll come in a wheelchair, I need help to get to the department. It is not as massive as you think. It just needs planning. So, as I said, even going to appointments has to be thought of. If the operation is to your arm, ask your surgeon or the preoperative team, how long before you're allowed to move the joint? Now, for example, rotator cuff surgery usually has a splint sitting out, getting your arm out there. And that's a long time. It'll sit out there for quite a while. How will this affect your self-care? How are you going to wash yourself? In the hospital, you have nurses, and the nurses will help you because they have to get their job done. But when you go home, there's no nurse to help you. Yes, right. As simple as pulling your pants up. Simple as, more so, how do you wash under your armpits? How do you wash behind your back? How do you wash the back? How do you go to the toilet? Who's there to help you wash yourself? They are real questions, and you have to address this problem. Independence, your independence in the home, that's my other mantra, again and again. Whether you have surgery or not, you are independent and you're staying in your home because of your arms, not because of your legs. Okay? So please respect that arm, treat it with care. What sort of splint will you be wearing? Will you be able to take the splint off and put it on by yourself? What happens in the shower? Do you have to wrap that splint in plastic? How are you going to do that? Are you left-handed? If it's on the right hand, and unfortunately, like the leg, the surgery is often to the hand that worked the hardest. Now you've got a non-dominant hand that you've never taught. So, unless you're ambidextrous, it is very hard to put a splint. It's very hard to even wrap a plastic around a splint to protect it when you're showering. And if you don't have a handheld shower rose, what are you going to do? It's going to get wet all over. So what sort of splint? How are you going to use your left hand? You must ask that question. If the operated hand is a stronger hand, dominant hand, are you strong enough to use a mobility aid in your weaker hand? Now that comes the telling time, isn't it? Even if you can use a stick. If you use your stick in the strong arm, which all of you obviously will. Now if the strong arm is operated on, how are you going to use the stick in the weaker arm? And are you for starters, are you ambidextrous to use it? If not, you have to use a chair. To be safe, you have to go into a chair. So you're one step down. So if you have to go use a chair for any period of time within your home, how are you going to maneuver the chair with one arm? Okay, so it's easy for us to say use a chair, but how are you going to do it with one arm? And remember, think if you're on your own, or if you are the strongest spouse, who's going to be pushing? Who's going to be standing behind the chair? What will taking weight on your weaker arm do to the shoulder? Because now that weaker arm has to become the stronger arm to do all the tasks for you. If you put extra stress on a weak arm that you've not strengthened, we've spent the last 2 days talking about strength, fast twitch, fast acting muscles, slow acting muscles. Have you built up all of that strength in the weaker arm so that it can keep combing your hair, it can keep making the bed, it can lift a small casserole dish or a pan from one point to the other? Is that arm strong enough? Even to carry a cup up to your mouth, is it strong enough? More often than not, it is not. We are not left-handed. We are not ambidextrous. When can you start? You've got to ask the doctor, when can I start carrying an object with the operated hand? Even if you can use the operated hand like a balancing aid. It's like a prop. That'll help. When can I start doing that? Then I can manage on my own. But when is the big question. And only the doctor will tell you. And often he'll say, I'll tell you after the operation. Because he's got to go in and look at your joint, how bad the joint is. And he might come out and say, God, it is, look, it was starting to fall apart, and I had to do this sort of more complex surgery. And he truly can't tell you that before. Often they have to go in before they can tell you. But you need to have this prepared before the operation. And again, will you have access to physiotherapy and occupational therapy? You must, this is very important for all upper limb. Make sure the occupational therapist does talk to you, because that's now when you're going to need all those aids, those extra aids to help you. And you must have physiotherapy after any arm operation, because it's the factor that keeps you independent. You must regain strength. You must regain power in your arm. If the operation involves, before I go off the arm, another problem with arm operations, and I've told this before, is if they operate, especially the elbow, it's a very difficult joint to rehabilitate as a physiotherapist, because arm operations you never regain full straightening of the elbow. You never do. Now, many of you use elbow crutches, and you're dependent on locking the arm dead straight against your body. Okay? You very rarely walk like that. Okay? Now, when after the operation, at the most, we might be left with what we call a lag, a 5-degree lag. So it's never dead straight, it's 5 degrees short. That 5 degrees short can make a difference between able to walk and not able to walk. So you must please think about this. If it's too much, at least get the physio to talk it through with the physiotherapist. Yeah? If the operation involves your leg, will you need a walking aid? Again, the same question, because obviously you must. Most operations on the leg, unless the doctor says you can stand on the plaster immediately post-operative, and even then pain is a big factor, and you must ask, will I need a walking aid? What sort of walking aid will I need? When a joint operation involves the stronger non-affected leg, as is often the case, inform the medical team that you may not be able to take weight on the polio-affected leg. You cannot hop on the leg. You've never hopped on the weak leg. And those of you in calipers, don't forget that caliper makes you apparently strong. It's irons. So that caliper leg is super strong because it's actually supported by irons. So the operation is always on the weaker leg. So if the operation is on your polio leg, actually it's not so bad because you've never taken much weight on it anyway. It's not an issue. So again and again, the stress, the point I make is the operation on the stronger leg, and often is the case. You need to ask these questions. When can you put full weight on the leg? This is very important because of what I've said. You can't hop on the leg, and should you need a wheelchair? Now the wheelchair question becomes more important now. And if that's the case, have you got strong enough arms to push your wheelchair? There are one or two of you who have polio affecting the arm. And if you have an operation on your abdominal surgery, any leg surgery, it's going to actually put you back a bit. Because you can't use your arms, you're now dependent on somebody else. And the pain won't let you stand straight. It will put a lot of load on your leg. Many of the patients who have weakness in the arm, I can pick you because you tend to walk almost like the army. You have to, because you can't afford to bend forward because you fall. So if you look around the room and see who walks like as if they're still in the army, you'll know they've had an arm problem. Are the joints in your arms strong enough to take the stress of taking load off your leg? Now, this applies also to abdominal surgery and spinal surgery. Okay? Is your arm strong enough to use the walking aid or whatever aid you need. And often when you do leg surgery, say for example hip replacement or knee replacement or even knee surgery, if you have arthritis and you can't use what we call the Zimmer frames, the standard frames that are in hospital because you can't load your joints, they're too painful, the physio may give you a modified, this rollator frame with gutters on it. It's quite big, nice and tall up here. So there are two versions, either pulpit frame, it's literally like a pulpit where you lean on it, or it's a gutter on the side. But both are very big frames now. Okay? Sure, you can use it when someone's watching you, but from that frame to go down to onto your toilet, and then to get up, because you've got to pull up onto that frame, and your shoulder doesn't go beyond 90, how are you going to do that? So unless your bed at home is electric high-low bed that comes right up as high as possible, then it's easy, because that's the bed you use in the hospital. Okay? Remember that. The hospital bed comes right up. You can just slide off the bed and use that frame. What about home? What's going to happen at home? Okay? So there are minor points, but that makes the huge difference to what happens to you when you go home. So they become really important. So when can you then put full weight is for the obvious reasons, do I need a chair? So if I can't walk on this leg for 1 week, I can sort of manage around. My wife will look after me. She'll bring me my breakfast and dinner and lunch to bed. And I just need to slide across to the toilet. But if I've got to do this for 3 months, I've got to seriously think about my options. Or even 2 months. As I said, we've gone through that. Are the joints in your arm strong enough? Okay? If the leg goes, is the arm strong enough? If the arm is operated on, is your leg strong enough to take your body weight? One part of your body must be strong enough. How much bend are you allowed at the operated limb? This will affect, as I said, like the arm, for the leg, it affects the chair height, the toilet height, and affects all your transport. So you may have an adapted cushion in your car. But what about if you have to go in a taxi? So you've got to lug that cushion around because you can't sit beyond 90 degrees in your hips for hip replacement. For knee replacement is the same thing. But some more doctors are, because of the way they do the surgery, some doctors, some specialists appear to be able to allow you to take full weight sooner if you've got no pain. So now you've got medications. Remember what medications do to your muscles also. They are very strong painkillers. You need them because you need to walk on your legs. Equally, we went through this exercise. Medications can cause a lot of weaknesses by the way they work. So you have to be aware of that you will need. I suppose end of the day, if you're strong enough, this is not a problem. If you're strong enough, it's not going to be an issue. You will manage. So, and you may need, if operations to your leg, you may need a shower chair to be able to shower safely. Who will give you this? Who will supply this? So don't assume the hospital will. It has to go with you or before you. How are you going to take that shower chair with you in the car? Who's going to, if you're on your own, who's going to transport it? Fine, the nurse will put it in the taxi. That small problem of if the taxi man just puts it out in your front door, how's going to drag it into your home? You've got to think about all of the logistics to the nth degree. Then it's not a problem. You can ask friends. All of us have friends. Somebody can come and accompany you. So you need to know, I'm taking all of these things home. If you rely on momentum of your lower part of your body to swing out of bed, you might need bed rails to help you sit up or move in bed. You will need to rely on arm strength for a while. Do you need a physio and an OT assessment of your home to assess how you normally do these activities and what environmental changes need to be made? Many of you don't realize this. Many of you, especially with lower limb and trunk weakness, you actually swing. You get your legs up and you've got a unique style of swinging yourself out of bed. You use momentum to throw yourself out of bed. Any operation from stomach to the legs, even to the arm, don't allow you to do that. We don't want you to swing. We want you to move carefully. So if you move slow, you have to pull on something to sit up in bed. Are you strong enough for that? Okay. So this, in fact, is more important, that you must have the OT and or the physio come to your home to see how you actually move. I've often given the story of one of my clients who used an electric a scooter for all her mobility needs because over time she lost the ability to walk on her legs. She could stand and transfer, but she couldn't walk. She needed operation on both her shoulders at some point in time. But she had a very unique way of getting on and off the toilet. That if I hadn't, it's by accident I asked her the question. She said she transfers front on, which means she wheels a chair facing the toilet and just goes straight forward and then comes straight back. Now, that is so unique, I wouldn't have even asked the question. So it's very important that we see, especially those of you who need shoulder surgery who are in wheelchairs, how you get out of the chair. Have you got a dominant side? Because all bathrooms, I suppose most hospitals have a wheelchair access bathroom, but sometimes it may be on the side that you're not used to getting into. Okay? You have a preferred side. So you're now stuck. Where you could be independent, you're going to need help. So you must tell the nurse, hey, this is on the wrong side. I can't move from this side. I might have to turn my bed around in the home because often hip replacement surgery requires you to get out on the operated side. The doctor doesn't want you to drag your leg across the bed and dislocate the hip. Now, if you are used to getting out on the left side, you're stuck. So you have to move your bed to the middle of the room. Who's going to do that? So can you see how important it is? Small questions. Hospital is fine. Everybody's there to help you. You leave the door of the hospital, there's no one. You're on your own. So you need to have everything ready at home. And do you have enough space in your house for those big wheelie frames? What about carpets? If you have nice, lovely, thick carpets to keep it warm, you've got problems with pushing any of those frames over thick carpet. So bring these issues up early. It can be addressed. There's a way of handling it. But it needs to be brought up before the operation. Other issues that you do as normal lifestyle. Most of you look after your grandchildren. If you're out of commission for 3 months, I think your daughter or your son needs to know that. Because now your grandchild has to go to somebody else for 3 months. Because you're not going to be able to run after them or pick them up. So ask the question, do you return to driving? Because many of you drive for your independence. When will you go back to driving? A very important question to ask. Because there's a lot of high cost affected with not driving and getting to activities. Many of you have social activities, so consider the community and social activities that you are involved in. Consider how the operation will impact on these activities if you have to use an aid. For example, carrying on with volunteer work, attending meetings. Now, if you have a frame that you have to walk with, how are you going to access now? Is that a ramp that you can walk up? Because you shouldn't have to stop your activities because of the operation. An operation is aimed at getting you better, not making you prisoner in the home. So ask the questions. Again, night activities are affected. Who is going to be responsible for transport costs if you're going to use a wheelchair taxi or a taxi all the time? So always go to the doctor with written questions. Because all of us have performance anxieties. I have a question, but I go to the doctor, I forget to ask it. And often, it's not that. Many of us in allied health, we are busy with planning. I'm talking to you, but I'm planning what I'm going to do next. We have that distraction. And so, we appear to be hurrying. A doctor has 10 people waiting outside. So you have to be sure that you have all the questions written down. And don't walk away without answers. At least ask the doctor, who can I go to ask all these questions? So have a name that you can go to. Now, depending on protocols, particular to each health service, the medical route is usually a referral pathway, meaning what the doctors do when they see you, they refer you to so-and-so. So a doctor who sees you in his pre-operative clinic will refer you to physio. He will refer you to occupational therapist. Okay? So his role is not to make sure it's done. He just writes a letter and sends it to somebody else so that in the end your health service looks at it and says, yes, the doctor asked for this service, therefore we will pay it. Can you see that? It's a cost problem. It's not wrong. It's the way that's the protocol. But he's not the one giving you the service. So you've got to make sure that that the referral has gone to the physiotherapist. Okay? Because, as many of you have said this story before, that you have mentioned to the nurse about the anesthetic, but the surgeon doesn't read all of your medical notes. It's supposed to be the anesthetist. And often the anesthetists will sort of, come talk to you and then walk away. So you have to make sure that that medical referral has gone to the right person in the right. So that's what I mean by the medical route is usually only a referral pathway. If you're seeing a physiotherapist or an occupational therapist or a social worker, put the question to them because your allied health team, that's what allied health, your allied health team is your service pathway, okay? We are the ones who have to do the hard yakka to make sure it happens. Okay, the doctor only refers. So make sure it happens. I do not know that you saw the doctor 2 weeks ago and the doctor wrote a referral. I don't know this because I'm sitting in the physio department. And really, the most efficiently run hospital does require everyone to follow a protocol. That's why we can service very quickly. So we are depending on the system working for you. But you are dependent on the information getting to the right person. So who makes the connection? Unfortunately, it is you. Okay? You are responsible. So please make sure it happens. Yeah? That whatever you need, it is done. And you have talked to one person who knows where you go for help. Sharing experiences and solutions via a newsletter is a good way of problem solving. We may not have all the right questions. You may not have all the right answer. So please don't use your newsletters as a complaints department because it gets nowhere, Even you get fed up of reading, oh God, another complaint. But if you can write solutions, and I had this problem, this is how I resolved it. It worked for me. Someone else might run with it. You never know. Because you resolve problems in a very unique way, unique to your requirements. So in summary, facing surgery, questions you must ask and information you must have. Always reduce the intensity of rehabilitation by half. If your physio says you must do 10, he gives you a sheet, and the sheet says do this 10 times, do this 20 times, you do it only 5 times. And if your physio says why, you give her the information. So say, for polio, we have to reduce the intensity, otherwise you make me worse. But I must do the exercise. So reduce the intensity by half. Always expect rehabilitation to take twice as long. So even if you reduce the exercise by half, take twice as long to do the exercise. Just slow down. Be careful. Okay? Take twice as long. That applies to the exercise as well as your bed stay in hospital. Always expect your bed stay in hospital to be twice as long as the normal protocol. So we have discharge protocols within 3 days, within 5 days, everybody must be out. I've had an 81-year-old man with aortic aneurysm, who is a polio. He was crying on the phone to me, saying, Jega, the physio wants me to walk up the stairs because for heart surgery, we ask patients to walk up and down stairs so that we know that they can take the stress. He never walked up and down stairs before. How is he going to meet the protocol? So, and it was sad for an 81-year-old to be crying on the phone. That is sad. Okay? So please never let that happen to you. Successful surgery does not stop at the surgeon's table. If only we could pay the surgeon after we have been fully rehabilitated and we are totally functional. So can we please do a revolution here? We will pay the surgeon only when we have been successfully rehabilitated. Because what's the point of having a new hip if you can't walk on it? So success must be measured by how quickly you can return to normal activity. So that might ensure that you get the right rehab quickly, because it means money now. The key to good outcome is thorough planning. Okay? Thorough planning is when you will be successful. Thank you for listening.